Okay, so my evidence-based project is on reducing catheter-associated urinary tract infections. My outcomes for this presentation will be the listener will list 3 ways to reduce catheter-associated urinary tract infections by the end of this presentation, as well as the listener will differentiate appropriate versus inappropriate indications for a Foley catheter placement by the end of this presentation. So, I chose this topic because during my preceptorship, I was floated between many different units, including second surge, third surge, fourth south, and so on. I saw many clients who had indwelling urinary catheters that potentially could have been removed days ago, but were still in. One particular client had a urinary catheter for kind of really no reason at the time when I was taking care of him. So that was still in the days when we were still in centricity and we had to go between the paper chart and the computer. And so one day I went digging through his orders in his paper chart, and I found that a few days ago there was an order to remove the Foley catheter, but today he still had it. So that kind of prompted me to kind of look into more on urinary catheters, and so I went down to the library and started searching for protocols, and then started to look for research articles to see if I was going to find anything different than the current protocol right now at St. Joseph's. So a few key points for this presentation will be on catheter-associated urinary tract infections. They are the most common and most preventable healthcare-acquired infection. The duration of catheterization is the greatest risk for development of urinary tract infections. And once inserted, catheters tend to remain in place long after the appropriate indication ends. And sometimes clients only get their Foley catheters removed right before their discharge is ready. So I found this really interesting Cotty song that I want to take a listen.
I remember when I had to go the first time, and I just couldn't make a flow. Frustrating. I needed you, that's all I really know. And you were there for me. Then came the day that they took you away. I was grateful all during the day. Then came the night and I felt some pain. I say, I need you. You come back, I love you. Ooh, I needed you again last night. And I'm so frustrated without you. But we are never, ever, ever getting back together. We are never, ever, ever getting back together. I am not in ICU or have open wounds or can't be. So we are never, ever, ever getting back together. Like never. The doctor told me that you had to go. I cried. He told me that infection would follow. Uh-oh. He assured me I would learn to go without you. I knew then that you had to go. It was so hard being without you. I have been just stuck to you like glue. The freedom I have now is oh so new. I don't miss you. I'll never miss you. I thought I needed you last night, but this time I'm telling you, we are never, ever, ever getting back together. We are never, ever, ever getting back together. I am not in ICU or have open wounds or can't pee. So we are sleep. This is exhausting. Are never, ever, ever getting back together. We are never, ever, ever getting back together. I am not an ICU or have open wounds or can't be. So we are never, ever, ever getting back together. We are never, ever, ever getting back together. We are never, ever, ever. This time, I'm telling you, we are never, ever, ever getting back together. We are never, ever, ever getting back together.
Okay, so hopefully that got you in the mood for Cotties. Okay, so why is this important? This topic is of great importance because even though catheters have brought many advantages to the healthcare, they also have big disadvantages if used improperly. Statistics have shown that infection rates from catheters rise higher and higher to the point that Centers for Medicare and Medicaid Services have stopped paying for catheter associated UTIs that happen in the healthcare setting. Let's see. So, urinary infections are associated with increased length of stay in the hospital, which increases client healthcare costs. Like I said again, Centers for Medicaid and Medicare Services have stopped paying for urinary tract infections that were acquired in the hospital setting. And catheter associated UTIs can be dangerous, costly, they increase risk for sepsis, increased length of stay, and in severe cases can result in mortality. So this is the indwelling urinary catheter removal protocol at St. Joseph's. It was revised about 2 years ago, so June of 2014, and this policy is up to date with current evidence-based information regarding the appropriate indication for placing a Foley catheter and instructions on when it should be removed. So, let's see. In right underneath the second um, point here, it says RN to assess patient continued need for indwelling bladder catheter upon admission or transfer, and each shift thereafter using the following criteria. So at least one of these following criteria must be met for leaving the Foley catheter in. The client either has to be on hospice or comfort care or palliative care, accurate monitoring of urinary output, say if that was a really critical ill client that needed strict INOs, a client with bladder dysfunction such as acute urinary retention or a neurogenic bladder, urinary outlet obstructions, so like enlarged prostate or kidney stones. Let's see, wound healing with urinary incontinence. Let's see, surgery or some kind of study, epidural catheter in place, or drug protocols such as client who's on diuretic therapy, and lastly, immobilization due to trauma or surgery. The protocol also states that urinary catheters is to be removed when the patient no longer meets the above criteria. So technically, the nurse has to reassess the client daily to see if the client is ready to have this urinary catheter removed. So my PCOT question is, the population is addressed to the medical surgical patients. The issue of interest here is the prolonged use of urinary catheters that result in infections. And the comparison of intervention, there's no really comparison because this policy is up to date. And I guess my aim here is that I'm reinforcing the policy for the nurses to take more attention and to daily reassess their clients. So the first study that I had is it's called "Reducing Your Use of Indwelling Urinary Catheters and Associated Urinary Tract Infections." Um, the author is Alpern et al., and this was conducted in late 2009. Um, they conducted a 6-month interventional study implementing a daily evaluation of proper indication for continuation of indwelling catheter until it was removed. So during the 6-month intervention, 337 patients had indwelling urinary catheters for a total of 1,432 days. 456 days of the 1432 total device days, 32% were considered inappropriate. In a comparison to the 11 months before this intervention took place, there was a 73-day per month reduction of urinary catheters. Also, in the previous 11 months, about 5 CAUTIs occurred per 1,000 days, whereas during this interventional study, there was 0 CAUTIs that happened in these 1,432 device days during this 6-month intervention. So results show a significant difference in CAUTI rates with implementation of the intervention to judge the appropriateness of indwelling urinary catheter. As we see, prior in the 11 months before the study happened, there was 5 CAUTIs that occurred, and when the nurses actually had implemented this strict policy of reassessing their clients and finding out if there is still a reason to continue their catheter or not. And we can see that 0 CAUTIs occurred during this interventional study. So here's a table from this article. Let's see, the table at the top here, it has 2 columns and it lists appropriate indications for continuing a urinary catheter and inappropriate indications. So some of them could be urinary tract obstructions or urinary retention, patient that goes into a procedure that is greater than 2 hours long, a patient who has an epidural catheter in place and can't feel anything below their waist. Frequent monitoring of urinary output required, so that could probably be a client who's in ICU and needs strict I&Os. Surgical repair or of decubitus ulcers, and movement intolerance due to terminal illness or severe impairment, which could probably include like patients on hospice or palliative care. So those are the appropriate indications. Some inappropriate indications are incontinence without any of the appropriate indications. So, like if the nurse decides that they're just going to keep the catheter in place because their client is incontinent and it's more convenient for them to have a urinary catheter for that client. That is one of the inappropriate indications that the client should not risk the infection of from this catheter, and the nurse should be taking that catheter out. Let's see. This graph at the bottom of the screen, it shows when the study was done and that when interventions did take place, uh, the number of urinary catheter devices days by month, so they decreased. Okay, so the second study took a look at they conducted an 8-month study comparing incidence of CAUTI following immediate and 24-hour postoperative removal of a urinary catheter. So this actually was a study on female woman who went in for a C-section, and all of them got a urinary catheter placed, and they divided it 156 women into 2 groups. So group A had 79 women whose catheters were removed 24 hours post-op, and Group B had 77 women whose catheters were removed immediately post-op. The study demonstrated a higher incidence of significant bacteriuria after 24-hour catheter removal compared to those whose catheters were removed immediately. Despite the benefits of Foley catheters, incidence of infection rises each day the catheter remains in place or in the bladder. Complication of catheterized patients may include fever, pyelonephritis, bacteremia, and in critical cases, possible death. A study number 3 that I had was called Nurse-Directed Interventions to Reduce Catheter-Associated UTIs. The main author was Oman, and this was conducted in 2011. They conducted a quality improvement project to test the impact of nurse-driven interventions on current evidence to reduce CAUTI. So pre and post data was gathered indicating a reduction in indwelling catheter days. Oman states that even though evidence-based guidelines exist for indwelling urinary catheter management, they're not consistently followed. So, re-education of nurses regarding placement, management, and early removal of indwelling urinary catheters found to decrease catheter days in this study. Approximately 50% of patients do not have a clear indication for indwelling urinary catheter, and catheters are often retained for days because of convenience, misunderstanding of their appropriateness, or lack of clear orders for removal. So, how does this impact nursing? Well, this policy is backed up by the best evidence that is most current research available and improves client care when nurses follow this protocol. When nurses do follow this protocol, the outcomes will have decreased unnecessary catheter placement, reduce infection rate, eliminate unnecessary antibiotic use in the case of when the client does develop a UTI, reduce healthcare costs, increase patient satisfaction, and provide high quality and safe care. So once again, here is the evidence-based St. Joseph policy on indwelling urinary catheter removal protocol. This is up to date with the latest research, and my goal is to enforce this policy use by nurses in their daily care of catheterized clients. Okay, so the conclusion is we're going to look at the outcomes again. And so the outcomes that I had in the beginning were the listener will list 3 ways to reduce catheter-associated UTIs by the end of this presentation. So here they are. The 3 ways to reduce the catheter-associated urinary tract infections are: 1, to identify appropriate medical reason for a Foley catheter placement. So not for the nurse's preference or convenience of having the client with the indwelling urinary catheter because she or he does not have to go and toilet the client. Second is daily evaluation of proper indication for continuation of indwelling catheter. So let's say the client has just returned from surgery and he or she has a Foley catheter in place. The client will probably have the catheter for a little bit of time once he or she comes off of anesthesia, and the nurse's part is to reassess the client periodically and to find the appropriate time when this catheter can be removed. And like that second study looked at, the sooner the catheters are removed, the less bacteria that is found in the urine that could possibly indicate an infection. And lastly, discontinue the urinary catheter as soon as it is medically possible. The sooner that the nurse removes the catheter, the less risk the client has um, to get this infection. And the second outcome was the listener will differentiate appropriate versus inappropriate indications for a Foley catheter placement by the end of this presentation. And so here it is. The appropriate indications for a Foley placement are if the client needs accurate monitoring of input and output of a critically ill patient, bladder dysfunction such as retention or obstruction, wound healing with urinary incontinence, gynecological surgeries or urinary surgeries, epidural catheter in place, um, immobilizations due to surgery or trauma, or clients who are in hospice or comfort care. Inappropriate reasons for a Foley are for nurse's convenience or patient preference. Some patients do like the catheter in place because that just means that they don't have to get up and go use the restroom. Another one that nurses really like to have catheters is when their clients are incontinent and they periodically, frequently, even have to come in and change that person because he or she is incontinent. So that is a very inappropriate reason for a Foley. And lastly, if the client is on some kind of therapy like diuretics who needs frequent toileting, a lot of nurses would probably prefer a urinary catheter, but that is another very inappropriate reason for a Foley placement. So here is my poster board that we will be presenting, or I will be presenting tomorrow at the St. Joseph Hospital. And it pretty much includes everything what I just covered. The nursing implications on my poster are pretty similar to what I had up above, but research has shown that in order to effectively reduce catheter-associated urinary tract infections, nurses must first identify whether the client truly needs a urinary catheter placed, according to the evidence-based guidelines, to avoid unnecessary catheterization. Secondly, the nurse must diligently assess the client with indwelling catheters daily for appropriate indication of catheter continuation. In fact, nurses probably should report this in shift change handoff when they report to the new nurse. They probably should report that, hey, this client has a catheter, and this is the reason why he has a catheter, and this is the goal when he can get off the urinary catheter. I think this is a very important step that can be taken to prevent infections. And lastly, removing the catheter as soon as possible, as soon as the indications are gone for the catheter. And so here are my references. And that is all. Thank you so much.